Welcome to the 4:00 workshop, Children's Crisis Respite. We're happy to have Gabrielle Rogers and Melissa Ramirez, Lauren Mitchell, and Madison. I don't know your last name. Gentrish. Okay. So I will introduce our speakers and then we'll jump right in. We do have, just as a reminder, the QR code for the survey on the door. So be sure to scan that and complete your survey. There's sign-in sheets on everybody's table, so be sure to sign in. For people online, we will drop the link to the survey into the chat. And so you'll find your survey for this session in the chat if you are a virtual attendee. All right, first I want to introduce Gabrielle Rogers. Gabrielle graduated from Texas A&M University with a degree in kinesiology and then went to UT to get her master's in social work. She has been working in the fields of mental health, child welfare, and crisis services since 2008. She's currently a program specialist at Texas Health and Human Services in the Children's Mental Health Unit, where she provides program oversight and technical assistance regarding non-physician mental health providers, children's crisis respite, and the inpatient care waitlist for children. And before I bring Gabrielle up, I'm going to go ahead and introduce our whole panel so I don't jump up in between. We also have Melissa Ramirez, who is the Director of Children's Services at Hill Country MHDD and is a licensed professional counselor supervisor. She's worked in community mental health for the last 11 years and is dedicated to the development of mental health services for youth. She is a proud Valley native and attended the University of Texas Pan American, where she received her bachelor's and master's degree in clinical psychology. She loves dessert, enjoys dancing with her puppy, and leaves all the lights on. Lauren Mitchell got her bachelor's in psychology and is working on her master's in marriage and family therapy. At the Youth Crisis Respite, she has served as a mental health associate, program specialist, and is currently the director. She takes pride in utilizing a collaborative and compassionate approach with families to foster hope, healing, and resilience. Page 2. She provides a safe and empowering environment where youth can take a break from ongoing stressors, process emotions, and gain a healthier sense of self. And Madison just joined their team, and she is the new program specialist. So we're glad you are all here today, and I will pass it off to Gabrielle.
Good afternoon. Can you guys hear me? Okay, making sure I'm holding it the right distance. So like I said, I'm Gabrielle Rogers. I'm the program specialist over the Children's Crisis Respite Program at HHSC. And I'm going to do kind of like a broad overview, and then I'm going to turn it over to the experts over here in the corner, and they'll present on their program. Make sure there we go. And so this is kind of a brief overview of what I'll cover. And it looks really long. It's not. So we'll kind of go over what Children's Crisis Respite is, the goals of our program, the providers and their location, eligibility, and the referral process. Do I need to speak closer to the mic? All right. And so the overview, so we contract with Children's Crisis Respite facilities to provide the services and treatment to children and their families within the community itself for Children's Crisis Respite. And these services are timely and include treatment planning and crisis interventions. The goals of our CCR pilot program are to increase access to short-term, safe, clinically appropriate placement for children who are currently in crisis, and which key is, but do not meet criteria for inpatient hospitalization. So these kids are needing some type of mental health stability without it being escalated to the point that they need hospitalization. So they're not considered a danger to themselves or others. We also provide transition planning services to children and their families in the adult caregivers or legally authorized representative before the child leaves the crisis respite facility. So the idea is that we provide that wraparound support to these children while they're in these short-term respite programs to help them manage whatever emotion they were having that brought them into the respite facility. So these are our current providers and locations. We have Bluebonnet Trails, MHMR of Tarrant County, Hill Country Mental Health and Developmental Disability Centers, and Heart of Texas Behavioral Health Network. And these are all of the counties that they cover. that can utilize children's crisis respite. So it's not a lot of programs, but it does cover a pretty decent size for our state. Current eligibility is they have to be under the age of 18 with a single diagnosis of serious emotional disturbance, or they can have a co-occurring with a primary as a serious emotional disturbance and the co-occurring being a substance use disorder or intellectual and developmental disability. And then they just have to reside in one of those counties under those service areas. And what's really cool about the eligibility criteria is that youth with lower IQs that sometimes get denied in some of our other programs can be served through this program. And so that's not an exclusionary criteria. So it kind of tries to help all of the children within the community. And the referral process is actually also one of my favorite parts about this. They can come from anywhere. It can be law enforcement, Texas Department of Family and Protective Services, the LMHA, schools, clergy, family, children can self-refer, can be juvenile justice, crisis outreach teams, emergency rooms, hospitals. Those referrals can come from anywhere because it's just a phone call. And they don't have to come like through the LMHA. And so this handout should be provided in the conference stuff. I'm not exactly sure how it is, but this is actually each of the providers' websites for children's crisis respite, and then the websites for HHSC themselves. And that is okay. Can you guys hear me now? Did you hear me before? Do I need to go back? No, we're good. Okay. I could do it again. It's very quick. So that's it for us. So I was just providing that big overview. And so next, and this is our email. If you have questions about that, that's a fancy underscore that you can't see that disappeared once it became a hyperlink. And we actually have cards out on a table out there as well with our, we're right at the corner with this email on it. So if you guys have any questions about the program, access to care concerns, just any general information, feel free to reach out to that mailbox. Yes. There you go. So that first one is the HHS Children's Mental Health website. And then Mental Health Texas is kind of the overview for all of the mental health services in Texas. And then I went to all of the different providers and actually linked their individual websites on here as well. Perfect. Okay. And that's it for me. So I will bring up Hill Country and they're going to do their presentation once I exit out of this. You need a laser. Yep, that's the laser. The red.
Oh my gosh, you shouldn't have given me the pointer. Just changed my life right now with that pointer. Good afternoon. Can you all hear me? You know, it sounds like I'm not talking very loud, but it's loud. Everybody's like, yeah, I can hear you. Calm down. Okay. Just want to make sure we're awake at the end of the day here. So my name is Melissa. I'm the Director of Children's Services with Hill Country MHDD. So I'm going to kick us off on this presentation. Throughout the presentation, you'll see different pictures. All of these pictures are real pictures of our home. No stock photos here. This is actually what our home looks like. So we've got our house, our big red van, just for fun. His name is Clifford. And we utilize them on the daily. So I wanted to kick us off a little bit by talking a little bit about what crisis respite is and how it's defined through different agencies, different programs in the state of Texas. So when we think of child crisis respite, our line item V talks about respite, it being short-term, them, as Gabby had mentioned, not meeting that criteria for inpatient hospitalization. They need support. It's usually under supervision. And then if we go to TAC also talks a little bit about crisis respite services as well. It also being temporary residential placement, usually. DFPS also has their twist on how they define that also. It's usually meant and utilized to support that caregiver or that legal authorized guardian to prevent impending crisis and to prevent relinquishment. And then Yes Waiver also has a definition for crisis respite as well, also meant to provide temporary relief for that legal authorized representative or guardian or that caregiver. Now, what we did is we wanted to take basically all three of them and kind of put them into one because they're all really needed for our youth and kiddos in our community. So
our respite program is designed to be preventative by reducing the need for more intensive services, such as psychiatric hospitalization, the use of the ER or non-medical emergency care, and the use of detention when it's not clinically appropriate, right? So one of the things that we noticed when we were first building our program back in 2015 was that when we look at the crisis continuum, there was sort of a gap in that care, right? So we didn't really have a lot to provide support to kiddos or families in crisis, besides inpatient RTC, or maybe they had a really good safety plan and we connected them with some community referrals. But sometimes families and kiddos need a little bit more. So that's where this idea of crisis respite for us came out of. So what is the YCRC? So our center provides services for youth between the ages of 13 to 17. It's for families that are in need of a short-term break from a pending or existing stressor. We create we're in a traditional home environment, as you saw a picture of our home. There's no automatic locks, there's no key card access. It's just a plain old regular lock, deadbolt, bottom door, and you're out the door. We have 24-hour supervision. We provide ongoing therapeutic interventions to kiddos and families and other support services in effort to reduce or prevent crisis. So we have our home designed off of a living room model. It very much so does look like just a regular home. We've got neighbors to the front, we've got neighbors to the back, we've got neighbors right across the street from us. It's not institutionalized or restrictive at all. Well, it's a little restrictive, and we'll talk a little bit about those. So our goal here was to prevent out-of-home placement or a need for higher level of care by providing those kiddos with skills that help them function better in their homes and in the community. So we did not want to see kiddos sitting in ERs. We didn't want to see kiddos going to detention. We didn't want to see kiddos going to inpatient care when that high restrictive level of care wasn't necessarily clinically indicated. But we didn't have anything else to provide, so that was the next best thing. So that's where Respite stepped in. We provide services that promote autonomy, empowerment, and social inclusion. So it's a pretty large home, but we are a 6-bed capacity home also. We provide up to 7-day stay in the least restrictive environment with 24-hour supervision. So a lot of times when we're doing interviews for staff, they're like, well, do we get to sleep? And I'm like, no, you are awake at night and making sure everything is copacetic in the home. So we have staff we are fully staffed, fully awake, fully operational, 365, 24/7. What's also really great about this program is these activities that our direct care staff provide, they're really individualized to target those kiddos' needs. So that was another thing that we were kind of seeing, especially for our families that have been in and out of sort of maybe the traditional TRR services. They've been in and out of community behavioral health. It's the same curriculum. It's the same skill streaming. It's the same, pro-social skill stuff. This gives our staff the opportunity to use that skill, but to sort of get really creative with how they employ that. So we're out in the community. We're partnering with Texas State. We're partnering with our local food bank who comes out to do cooking classes. We really, really want to hone in on what those kiddos' strengths are and build from that. Because every kiddo has their own internal strengths, right? Their own internal motivators. And so our staff does a really good job at getting creative in that skills delivery. And the crisis continuum. So when we think about the crisis continuum, like I've mentioned a little earlier, there wasn't a whole lot that we were doing before as a local mental health authority on our end. But for us, it is a continuum, right? It's that spectrum. So we might have a kiddo just entering services, right? They've barely encountered their first crisis. And so we want to make sure that they don't get there again. We might have kiddos that are exiting that more intensive treatment. So they're coming out of a state hospital or they're coming out of an inpatient care facility. And that step down, that's a big jump when you go from a very restrictive institutionalized setting to back home where you have free reign of everything. Respite is an awesome step down option, which they'll talk about as well. But for us, crisis is spectrum. So we look at crisis as prevention, intervention, and stabilization in our home.
Hi, I'm Lauren Mitchell. I'm the director of the Youth Crisis Respite Center. So I'm going to continue. What I want to talk to y'all about is trauma-informed care. So, Youth Crisis Respite, we strive to provide trauma-informed care in our environment there at Respite. Our staff all have wonderful education. They're constantly enhancing their skills and trying to promote that culture of safety and empowerment. When I think of trauma-informed care, I think about the saying, you can't read a book by its cover. Same thing goes with these kiddos. They're coming through. They're not just a diagnosis. They're not just that current crisis that they're having. They're not just a case number. There's so many things that they have experienced in their life that have led to today. So though they're coming in with a specific crisis, there could be a million and one things that are going on in that body and that mind. So when they come in, we make sure the family and kiddo knows that we are here for them and we're going to meet them exactly where they're at that day. We understand that trauma can happen in every which shape and form. This could be, we have kiddos that come through that they're victims of violence, sexual assault, there's substance abuse, poverty, bullying. I mean, there's just tons of different things. And so we make sure that kiddos, when they come through, they understand that we're here for them and we're going to meet them exactly where they're at. Building a TIC environment. So that board that you see right there, that's as soon as you walk in. So when families and kiddos come through, they're going to be able to see exactly who's working in that home. So I know for me, even just leaving my home, going on vacation for a few days, I can't wait to be back in my bed. It's just an uncomfortable feeling being away from your safe space or just being away from the place that you usually are. So we want to make sure when kids are coming through, they know exactly who they're going to see, exactly who they're going to meet. Sometimes kiddos will admit in the evening and then they wake up and it's totally different staff. That can be a little bit jarring, especially when you're going through a crisis. So we kind of introduce ourselves on that board. We let kiddos know, this is the staff you're going to see at this time. These are some of the things they like to do. A lot of the staff put their pets on there. And it's also really good topics and conversations that kids can spark up with staff when you're trying to build that rapport. So yeah, that's like a kind of an example of what we do at our center. We also, whenever we're doing our admissions, we have everybody sit at the table and we make sure that everyone's part of that process. So just because a kiddo is under 18 doesn't necessarily mean that they don't have a say in what that experience is going to look like. They also have their own consents that they get to specifically sign, and it doesn't have to do with the parent. So what is your experience going to be like? Do you consent to being here? Do you even want to be here? And we ask that kiddo directly. We don't ask parent or guardian or whoever's dropping off. We ask them, do you want to be here? And what do you want this experience to look like? And empower them to advocate for themselves and advocate for what they want to get out of that experience. That's a big part of that admission process. It's making kiddo feel like I'm important to speak up and let these people know what I want out of this experience. And I'm volunteering to come here. I'm not being forced to be here. Another way that we build that TIC environment is getting to know kiddos' interests, the things that they like to do, the things that work for them. So if I have a kiddo that's coming through and, they've been kind of experiencing some isolation issues, depression, you're not connecting with their community, I want to go straight in and say, let's work on anger management. It makes absolutely no sense. If I have a kiddo that's been struggling with isolation, there may be some issues with connecting with kiddo. They're not used to talking to people. They may get really nervous being out in the community. So what can you and I do? What are you comfortable with? What are things that make you feel fulfilled? And let's work on those things while you're here. I'm not going to work on things that aren't going to work for you. So we build that connection. We find out what those interests are. We find out what those strengths are, and we build upon them. Another way is we look at different preferences. So some kiddos love to be outside all summer. Let's go hiking. Let's go have a picnic in the park. Let's process about some of the trauma that I've been experiencing lately. Let's just be outside. I want to feel like I'm outside, and that's where we're going to work best. Some kids want to be inside the entire time in the paint room because that's where they feel safe, or by the bookshelf because they like to read and that's one of their coping skills. Then we will do exactly that. So it's not where we're just following the same curriculum every single day. We're doing what's going to work for the kiddo. We're meeting them where they're at, where the family's at, and we're going to cater the program to them. So each kiddo is going to have a completely different experience, and we're going to make sure that we provide that for them. Another thing that we acknowledge is that sometimes poor coping skills exhibited are really survival skills. So for example, you have a kiddo that's been running away from their home every single day. I might get that paper, that police officer report, and it looks bad. They've been running away. They tried stealing a car, they stole money because they wanted to get food. What does that environment look like? What are they running from? Are they trying to survive? What is the issue? There's so much more in that system that we can look at. So that's what I mean, that kiddos aren't just that assessment, that screening. There's more to the picture, and our staff strives to dig deeper, cater the program to them, find out what's really going on, and break that cycle, figure it out. So this is a look inside our center. These are a few pictures. Our kitchen, very much just like a home kitchen. The staff and the kiddos work on their meals all together. Like Melissa said, we partnered with the food bank, and they would come in once a week and teach a full cooking class, and the kids would have access to all those things. In more restrictive and clinical settings, they typically don't have access to knives and forks and can openers. Here they do. And of course, we use caution and we monitor all those things. And we do have kids that have come through that have had some self-injurious behaviors, and we communicate. We open up those lines of communication and we let them know, if you feel uncomfortable, you feel unsafe with certain objects out, let's talk about it. I can cut all the vegetables, and maybe you can saute and season them. And we make it kind of that family effort, because part of this whole living room model thing is that we want them to mimic those behaviors at home. So could we make our own meals? Could we be healthy? Could we have these healthy coping skills at home and do family setting type meals? So staff really encourage kids to participate in all of those meals, snacks, breakfast, lunch, and dinner. All of that's together in that kitchen. Our living room setup, we have our couches, there's a bookshelf, we have our DVDs for some downtime. We also have a Wii that kids love to use. We have a bunch of exercise DVDs, and kids get on there and have a blast. And it's kind of the staff's time to not have to think about anything, just have fun with the kids, become a kid. And it's just like a whole laugh attack there. It's just so much fun. Our reading area, that middle picture right there, that's kind of just a lounge area in our activity room. We have some kids that they want nothing to do with arts and crafts or anything outside. They just want to be. They just want to rest. They just want to sit there because maybe chaos has just been the top headliner at home. So they rest. They sit there. We have a very calming environment. That's where they sit and process and talk to staff. We just want to make sure that, we're meeting those kids where they're at. If they don't want to do anything, that's fine. Let's talk about it. Let's just chill. Let's just hang out. Our activity room, that picture all the way on the other side, there's some masks on the floor, some canvases at the top. That room is exactly what it sounds like. It's our activity room. It looks like Hobby Lobby in that closet. We have anything and everything that has to do with crafts. Some of those things, kids come up with their own things that they want to do. And they're like, oh, did you know if you mix this, we can make glitter slime that sticks to the wall? Sure, let's do it. And so we're constantly restocking all of that, making sure that we have things that we can do with kids, that we can get creative, interesting things, looking at therapist aid, just anything and everything that we can do to help these kids succeed. This is the last slide for me, holding space for yourself. That is a huge, huge thing. So Respite, it's a place of rest. So though we want kids working through their crisis, we want them to process some of the really hard things that they've gone through. We want to see these magic turnovers whenever they come through. Not always are kids ready for that. All they're simply ready for is a break. They just need rest. And the mental health field inside of you just want to make all these changes and you want to fix everything and you want them to leave and just thrive and do all these wonderful things. But sometimes kids, they just don't have the capacity for that right now because this trauma, this crisis that they're into, it's so heavy. They just want to rest. They want to be in a place that's safe. They want adults to listen to them. They want people to just be there and nurture and provide a good meal, provide a nice living room, just be in a safe home. And so we encourage them to do that. If you need to come here to just rest, to become fulfilled so you can go back out into the community, to go back home, you need to reflect, you need to process, whatever you need to do, hold that space for yourself at Respite, and we could provide that for you. Actually, this is mine too. Never mind, you still have me for a little bit. So the YCRC process. So there's two ways. So as Gabby had mentioned, we do cover a wide expansive area of counties in Texas. So Hill Country MHDD, we are across 19 counties. So that's pretty widespread. So sometimes our kids are already in services and, our staff will recognize that there's a need and they will conduct that crisis screening and that referral process begins. Sometimes it is our community partners. So our schools, our fire department, our law enforcement, a librarian, people that we've made connections with throughout our counties that recognize that there is a need for respite for this individual. So from there, kiddos will contact, well, not kiddos, parents, whoever, they will contact the crisis hotline. Though rewind, we have had some kiddos contact the crisis hotline because they knew about our program or they were repeats. But pause. Okay. So they will request that screening. That process will begin. There's a screening and assessment, a series of questions that will kind of look at what that need is. Are we looking more of at a big clinical need where hospitalization may be on the table? Or are we looking at this kid just needs a break from this system, from this environment? Maybe it's the family, there's some discord there. Maybe a break is just needed. So that assessment kind of tells us, where is this kid falling on the spectrum and how can we get the appropriate care for them? From there, that screening is sent to me and I will staff it with that screener and we will talk about what's the situation. I typically have a whole bunch of follow-up questions that aren't in the screening because I also look at my milieu, kids that are already in the home. Can they be successful while this other kiddo also admits? What does that look like? Staffing, the home, weather. I mean, just there's a bunch of different things. We want to make sure this kiddo can be successful. We staff it, we talk about it, we make sure that kiddo is appropriate for the program and they can leave that home feeling successful and having the tools that they need. And then from there, we will do that admission process, family admission, all sitting at the table, talking about everything, kiddo being part of that process. Go through the program and then they will have the discharge and we will do it the exact same way. We all sit at the table. We are all discussing the safety plan. Kiddo has a say so. And these are the things that some expectations that I have. These are the things that I need. These are some things that I've learned about myself. Parents talk about, these are my expectations. These are some of the things that I've talked about. We have a really great group conversation, connect to resources, see if kiddo needs to get into services, if they need extra community referrals, what can we do to set up this success? And then they discharge from respite. Kids do have the option to come back through and repeat, come back. Parents will do that same process to get back in. And then sometimes we're just doing outreach with our schools, reconnecting with people. And if they don't know about our admission process, we're constantly connecting and letting them know what that process is so we can build upon our program. Now that's it for me. I'm going to pass this on to Maddie.
Hi, I'm Madison. I'm the program specialist at the Youth Crisis Respite Center. So Lauren talked a lot about how it was voluntary, which is such a big part of the program. We need buy-in from both the parents and the kiddos, because that's what's really going to make the difference here is them working together, making that collaborative plan to move forward and what to work on and how they're going to do that. So that collaborative admission looks like parent and kiddo sitting at the table, like Lauren just said, talking about how it's going to go, what are our expectations, what are the goals going into this, how do we plan on working on it while we're here, and then how are we going to transition that back home and how are we going to get there? So it seems like a long step that we get accomplished in such a short amount of time in those 7 days. But the programming is really unique. So we can build in the legally authorized representative into the schedule. So whatever our schedule is, we can build that in, whether it's coming to have dinner, whether it's coming for game night, we're adding those supports into their system and adding that to our program so that it can be one whole holistic experience for them so they can combine all of those things and really learn how to do those things when they transition out of respite. While they're there, though, we are doing routine check-ins. So we're checking in with parents, we're checking in with kiddos, or caregivers, I'm sorry. We're checking in with caregivers and kiddos, seeing how it's going, if we need to facilitate conversation there, what that looks like, and how we can kind of get through these barriers to make them be one operating system. And then the discharge is also collaborative. So during that discharge, we're going over the goals we set, what skills we worked on, the interventions we did while they were here, and how we're kind of going to apply that at home. Lauren talked about how the expectations are revisited. So we're revisiting, what do I expect when we get there? This is what I expected when we came in. And I kind of have a different opinion about it now, watching them go through the program. So they'll talk through those and what it looks like and kind of plan as the week goes on. Okay, so that coordination of care, it starts with the discharge, like I just said. So we'll go over the plan, skills, interventions, how we're going to get them to transition back home. And then we're also going to outline those appointments for them. So do you have an appointment with a clinician? Do you have an appointment with your care coordinator? What does that look like? And what do you have coming up so we can make sure that we can set you up to be successful? Adding to that, we're also sending them home with a safety plan, which is another tool that they can utilize while they're at home. So they get to take that home from Respite. They can bring it home, and it's a physical piece of paper. We're not sending home a copy. They sat down and they wrote it. So that's like a piece of their heart that they get to take home with them. They know that they had a piece in it and they can pull it out whenever they need it. Lauren touched on community referrals too. So as they're leaving, how can we help you? Are we connecting you with a food pantry? Are we connecting you to be enrolled in Hill Country Services? Are we connecting you to some clothing donations? What is it that you need that we can connect you with so that we can set the whole system up to be successful as we transition them back home? And then that last step is that continuity of care. So we're following up about 4 to 6 weeks post-discharge to check in and see how it's going. Did you have to use your safety plan? Was it effective? Were the skills you learned here, were they able to be transitioned back home, and did they work? So just checking in, seeing if Respite was a positive experience for them and kind of how they transition that back or what other referrals we need to make. So there are lots of benefits. The program benefits, like it was mentioned earlier, we cover such a large service area. So we cover 19 counties. So that's a lot of surface area for us to cover and a lot of opportunity for us to be there for the community and offer that service to them. Treatment benefits, like we said earlier, Lauren said they have so much autonomy. They have so much control in the decisions that are being made throughout the day that it's really their program. They're creating it. And so whatever they're putting in is really what they're getting out of it. Which transitions to the community. They're learning how to do these things themselves. They're taking them home and they're taking them back out into the community to be more successful citizens. And Melissa also touched on this earlier. It can be used as a step down for more restrictive placement. So they've gone to inpatient, they've gone to hospital, they've been in the hospital, they've gone to RTC, and they've done all the work, but they're not quite ready to go home because that's such a huge step down. So it can be used as that transitionary period to kind of see what it looks like, work out the plans that they had made while they were in other care, and test them out before they get there. Some challenges, because there's always no good without any challenges. So reimbursement for services. Respite is largely a non-refundable service. There are a few cases where it is refundable through Medicaid, through Medicaid and through Yes Waiver if it's in their individualized care plan. Funding is shifting, as we saw, for the better. Children's mental health has come to the forefront, and so it's now giving us more opportunities to grow and expand more than we have. Transportation is also a barrier. So at this time, we cannot provide transportation, but we cover such a large surface area. So it has been a barrier and a challenge to get kiddos from El Paso, Del Rio, from all the way around to get them into our services because it's just such a far distance for them to reach us. Going along with that is refusal to pick up. So we'll have parents drop off kiddos, and it's time to pick them up, and then we're all waiting. So it's collaborating, gathering with the people we need to meet with. How can we get this kiddo to a safe place? How do we get them back home? And how do we rejoin them with their family and kind of mesh through that and work through that to get them home? And then just an awareness and understanding of our services. It's not like we're going on a trip this weekend, I'm just gonna leave the kid here, which seems to be confusing to some people, but it's really about educating that we're here to work on this crisis. We're here to teach them these skills. This is not a place where we just casually drop them off to hang out. Even though it feels very relaxed because they have so much control and so much autonomy while they're here. And then if you can read on the boards, it's just some feedback that we've got from families and the kiddos. And some of them just strike you so deeply. Like it's saying, I'm happy I got a break and I feel better. I feel ready to do better at home. I feel rested and excited. 2 very important words, rested and excited. The staff helped me to learn to love myself more and take care of my mind by speaking kindly about myself. And then even from parents, the staff are genuinely supportive and have a system of learning for kids who are struggling. And that Respite helped their child so much that they thought they had tried everything before they came. And we'll turn it over to questions.
Yes. Yeah. Yeah. So unfortunately, we don't have accommodations for that. We've had some families that have traveled, 3 hours, 4 hours, driven over, and it's a long drive. So we'll have parents stay, have dinner, kind of rest. I think one time, a specific situation, a mom, she was just exhausted. I mean, you're going through a crisis, your child's going through a crisis, so the family's going through a crisis, the mom is in crisis. And so she just needed a break, and we allowed her to lay down, go into a room. No kids were staying in there. Just go lay down and rest for a little bit. But unfortunately, we don't give those extra accommodations like a hotel stay or anything like that. These parents do drive from their homes. They come over, stay with us, do the admission, and then they head on home.
For those family members. Okay, so here's the mic. So is there any plans possibly in the future in the community where your home is located for the child, for a family care type center for the family to be able to stay someplace where they have a support system? Ronald McDonald has the house, where the families stay while somebody is in the care of needing medical attention. Well, this is the same difference. So is there anything like that?
I don't have anything in place right now, or there hasn't been talk of it, but I will say that that's an amazing point, Ms. Kim. I think that that's a great idea. And I do agree that that family could use that extra support also. But it's something that we can take with us, and we could take it back home and kind of think about that also. But that's not something that we've had in place before. I think even have plans to right now.
I will say one of the things that we when we talk to parents, like our peer support team talking about respite, is we always get the question, and what about adult respite? Like, when is that happening for parents? It's a wonderful question. It really is. But the way I look at respite also is it's a break for the family, right? Sometimes as caregivers, we get overwhelmed, we get stressed. What we don't want to do is exacerbate a crisis where there's maybe risk of relinquishment. So we let them know, like, if we're coming to like a difficult time period, like in July, that's when I lost a loved one. It's very difficult for the whole family. I know that's going to be a huge burden on me as a caregiver. I would like to use respite as a prevention service. I love that idea. As long as it's appropriate for that milieu, that might be something that we plan for with Lauren, and it gives that family member that respite. Now, it gives them the respite at their own home, so they still have to travel, but we're hopefully lessening that burden where they get to sort of have that respite internally in their own place.
Yes. So right now we currently don't have a wait list. There have been times, typically right at the beginning of the school year, when things get really stressful for kiddos, where we have a lot of kids coming through. And so it may be something as short as you don't get to admit right now this evening, but tomorrow morning, because we have a discharge at this time. And it's kind of just that revolving door of kiddos coming through. But we've never got to the point where we're so full that we have to say, no, we'll see you in a week. No, not as of to date. Yes. It's a 6-bedroom home. Yes. Sorry. I'm so sorry.
If we can use the microphone,
Okay.
because our virtual attendees won't be able to hear the questions.
Oh, yeah.
And I'll try to walk back and forth, but can I get these over here and then I'll go over there?
Of course.
I have two. So one of the questions is, what are the 19 counties that y'all serve?
I do not have those at the top of my head, but it is on Gabby's slide. She can bring those up.
Okay. So it's Bandera, Blanco, Comal, and I'm going to mispronounce these because I'm not from Texas. Comal, Edwards, Gillespie, Hayes, Kendall, Kerr, Kimball, Kinney, Llano, Mason, Medina, Menard, Real, Schleicher, Sutton, Uvalde, and Valverde.
And do they stay the full 7 days, or do y'all discharge early, like 5 days? Is it just 7 days overall?
Yeah, so it varies. Like I said, it kind of just depends on the kiddo. What is their level of feeling comfortable being away from home, and we're meeting them at that need. So sometimes kids will say, Mom, 2 days. That's it. That's all I'm giving you 2 days. And then frequently kids will say, I want to stay the full 7 days because it's a really positive environment. So up front, we offer them the 7 days and then we set a discharge date. That can be tentative if they change their mind. But typically kids will stay between the 3 to 5 days. That's kind of our average that kids, that's when they'll stay. But some kids do stay the full on 7 days. And then 2 weeks later, they want to come back because they just had such a great experience.
Thank you for the presentation. Do you provide respite services to foster care youth?
I'll let Melissa answer that.
So we have been talking with CASA recently to see what sort of collaborations we have. One of our biggest things is accessibility to that legal authorized representative and that foster parent. So they need to have authorization to make medical decisions on the kiddo's behalf. And they also need to be readily accessible. So like Lauren mentioned, if that kiddo says, I'm going to stay if that kid was anything like me, like on overnight, I'm like, yes, mom, please let me stay somewhere overnight. And then 8 o'clock kid, I'm like, I want to go home. Like, I want to go home and I'm crying. Sometimes we get kiddos like that, right? That aren't comfortable in new spaces. That guardian, foster parent needs to be available to come pick them up. And sometimes they are, but sometimes they have other life situations. They have other kids in the home that they're like, I cannot leave right now to come get this kiddo. And so that's really our biggest barrier there.
And I do want to add that I as the HHSC rep, we are currently working with our legal to try to get a process in place to work with DFPS youth for children's crisis respite, because to enter into children's crisis respite, it has to be a single case agreement because it's not a licensed placement, which makes it difficult for DFPS because of their rules and regulations. So we're working right now to see what to get a process in place so then all 4 of the crisis respite facilities can utilize this for DFPS youth.
Hi, I just have a couple real quick questions. If you could talk a little bit about the staffing pattern for the program, and then also with the transportation, since you don't pick up individuals and bring them to what do you do? What type of transportation do you provide?
So as far as, I'll answer your first question, our staffing. So during the day, myself and Maddie, we work Monday through Friday. And then we have 2 staff that are working that day shift from 8 to 4. Then there's a shift change in the evening. It's from 4 to midnight. And then our 3rd shift is from midnight to 8 a.m. So we have 2 people on each of those shifts. And then during the day, an additional 2 people. So no matter what, there's always another person there to support. As far as transportation during their stay, we provide that. So going to the library, going on hikes, they go do our grocery shopping with us. We all go to HEB together. Community events. I mean, anything like that, we will provide that transportation, but admission and discharge, that is the responsibility of the parent. Mm-hmm.
I'm going to follow up a little bit. So how do you bill for services? Do you use a QMHP and you bill for services that way, or how does that work?
Sure. So yes. So both Lauren and Maddie are QMHP. So if we're going to do a traditional TRR services, that is billable if they're currently in Medicaid. Now, I'm sure you know that's not a huge reimbursement, and the cost of respite is pretty large because we're thinking about the stay, the food, the utilities. All of that stuff is not a reimbursable rate. So it's difficult. It's a challenge. We're very fortunate to partner with our local community SHI board, which is our local clinic that they sponsor our local community health clinic there. And so they actually have bought the home and we lease the home for them at a very, very low rate. And they also currently pay for our utility. So that really helps offset some of those costs, but largely respite is not a reimbursable service.
So I know this is a pilot project for 4. Is there any indication in the near future that it's going to extend to other areas of Texas, like South Texas?
So a week ago, we came out with our needs capacity assessment at HHSC for expansion for children's crisis respite. So this last legislative session, we got a lot of money to expand this pilot program. And so LMHAs are currently going through the application process to either expand upon the current children's crisis respites or to add multiple locations.
Hi, I did have two questions. One, what is the educational portion while they're in crisis respite? Do you transport them to school? Do you provide schooling while they're in respite?
Yeah, to answer that, we do build that into the program while they're there. We definitely don't want kids falling back with their schoolwork because that can be an additional stressor and cause that stress and anxiety to increase. So what we do is when kids come through, if that's something that they're willing to do, families are supportive of that. Most of the time, our counselors, our teachers, and principals are very supportive of that. We get those consents, those releases, so that way we can contact the counselor. They can email me all of the work, and then we will build that into our day. So a couple hours here, an hour here, we're doing some study time before bed. And though we're not teachers, we provide that support. And if we need to Google, we figure out what we need to do to support that kid in their educational journey as well. And then as far as transportation, there's two options. Kids have gone to the bus stop. And of course, they would have to be going to school in that county where we're at. So they can go to the bus stop, go on the bus. We make sure, they're getting on the bus and they're coming back. We have those inventory sheets. They leave, they come back, and then they resume their day with us. Or parents can drive to our center, pick them up, and they will do that and take them to school so they can complete their school, not fall behind. And then they bring them back at the end of the day and they can continue with their groups, their dinner, processing, talking with staff, and they continue with the program.
My second question is there any diagnosis or behaviors that would cause you to deny a child?
Yeah, so it is very situational. We want to make sure we're setting up kids for success. So that's why I make sure that I do a really thorough staffing with the crisis assessor, because a crisis screening may say, let's see that maybe a kid is suffering from schizophrenia. And, they're hearing things, they're seeing things, but it's not necessarily impacting their day in such a negative way that they can't be successful and work on themselves and work through that and work with us and get into respite. So is there a safety plan in place? Do we have a full scope of what is going on? What do those voices look like? What do those shadows look like? What are these voices saying? Sometimes it's, I just see shadows and I hear voices, but I don't really feel anything. It's just kind of weird. Okay. I wouldn't want to rule that out. But if we have a kiddo coming through where those are commanding, it's impacting my day where I feel like I can't be successful, I can't stop thinking about these very intrusive thoughts, then yeah, we might need to look at more of a clinical setting for now, get the appropriate clinical help that you need. And then maybe you're using respite as a step down. So that way we can transition back home and make sure we're setting you up for success. So it's definitely situational. We look at each diagnosis the very same. We want to make sure we understand what's going on. We give every single kiddo a chance, and we want to make sure that we're setting up our home and our milieu and other kids that are staying there for success. And we're setting up that kiddo for success too.
I'm interested to understand how this works with Yes Waiver. Do you guys contract with Yes Waiver, other centers? Is that something? How does that?
Yes. So we do have a Yes Waiver at our LMHA. As long as it's on that kiddo's IPC, individual plan of care. I just learned that. I nailed it, didn't I? IPC, yes, they're eligible for our respite home. We actually just had a few kiddos from our Yes Waiver program come home. And Yes Waiver is a reimbursable service for us. So from another county, unfortunately not at this time. I don't know if that might change in the future, but at this time, no, unfortunately.
Hi, where was the contact information for like the referral process? Like who do you have to contact? Was it that email that y'all had on there?
So they would contact, if they're in services, they can contact the clinic, they can talk to them there, or they would have to call the crisis hotline and request a screening for respite specifically, not just a screening for anything, a screening for respite. So that way we can get them assessed and see if there's an appropriate necessity and, are we able to bring them into our program?
Okay. And one more question. Do y'all have children who are repeat, like come back?
Yeah, we definitely do. We've had kids The other day there was a case number that popped up and I didn't even remember he had been there maybe 5 times in years that I worked as a mental health associate. And I was like, my gosh, I did not remember him being there 5 times. So we've seen some kids admit at 13 and then they just we see them grow up and they're coming through, but that's okay because crisis doesn't just happen once, right? And they know that we're providing that culture of safety. We're empowering them to be active in their own lives, to kind of change their course, and they're coming back. The families are coming back too. It worked. We don't want to, hospitalization. We don't want to go through all of that again. What can we do to intervene right now? And yeah, we have had many kids repeat.
I remembered my question. Runaway and homeless youth.
What was that?
Runaway and homeless youth.
Yes.
That's something that I know is going on in Waco at their respite home, but I don't know if you guys do that as well. Is that something that you guys are working on?
So that's definitely something that I've been talking with Kelly about because they do a fantastic job of partnering with that population, and it's very needed. We are in talks. We are collaborating with the Comal County. They have a great shelter there for youth and adolescents, but it's not something yet that we're currently providing, but we're hoping to get there very soon. They're doing really great work at Harder, Texas. And shout out Terry County, also amazing work, by the way.
Does anyone, I think you had a question early on, right? It's gone. I'm so sorry. I'm so sorry. I remembered though. I was like, I'm coming back. I'm coming back. Oh, awesome. Got it.
You mentioned refusal to pick up.
Yes.
How often does that happen for you guys and how do you navigate it?
So not often, I will say that, which is great. Knock on wood, right? But really, everybody knock on wood. I'm going to get a call from staff. So I think the way that we navigate that is we really make that admission experience thorough, not only once, but twice. So I have my crisis screener explain to parents before they even head to our house. This is how it goes. This is a grant funded program. This is an amazing opportunity, but I need you to come back. You got to come back. If we're trying to set up kiddo for success, which is what this crisis intervention program is, you can't not come get your kid because that's putting them back into crisis. So you need to understand what this program is and what our expectations are. So we have our crisis screener translate all of that information that I need them to have. And then, of course, I want to make sure they hear it from me too. So when parents get there, we talk about it all over again. Before we even start that admission paperwork, we're not going to just start signing signatures. Let's all have an understanding of what this is. This is not a long-term placement. The goal of Respite is to get that crisis intervention, get that rest, take it back home and be successful at home, not stay here forever and be successful with us, because that's very possible. We could do that, but you need to be able to do that at home. So what we do to navigate that is, I'm just going on and on and on because that's a scary one for me, is we really, really make it detailed. So that's why we set that discharge date. Even if it changes, they want to stay longer, we set that date and that time up front. You see the paper, I see the paper, we all understand. And that if it needs to be longer, then we'll do that. But let's go ahead and make sure we plan for this. So that way you need to get your work schedule done. If you need to leave early, whatever it may be, we have it organized ahead of time.
And just because I'm the program specialist, so I work with all 4 crisis respite facilities. Tarrant County and Bluebonnet have both had some really awesome successes in the horrible tragedy of a kid being left there and working with the community and coming up with a collaborative way to support the youth in the community who's not returning home. So I think one of the really awesome things about all 4 of our crisis respite facilities is they're creative, they're out of the box thinkers, and they're really there to support these youth. And so the instances I've heard of, the centers have really stepped up to plan for these youth and make sure that they get back into the community. So they're getting provided for.
I had a quick question. How many students or kids do y'all serve that actually have like an intellectual disability? I'm with the Arc of the Capital area and we primarily serve kids with intellectual disabilities. So I'm just curious for your numbers, do y'all serve a lot of kids with IDD? I know emotional disturbance is a primary thing, but just wanted to ask.
Yes. No, we definitely do. I think one of our eligibility criteria though is the ability to function independently on their own. So those daily living skills, that's a must. So hygiene, shower, things like that. We can definitely support with the making the bed, the cleaning, the washing, things like that. But we do get kiddos that have co-occurring, have both. Some of them are primary IGD, secondary SED. That does also happen.
What was that? So we just have one home. It's in San Marcos. Yes. Okay.
The first question we have is there a schedule that is followed daily at the house?
Yeah. So we kind of have, our breakfast, lunch, and dinner. Those are at the same times. But because there's so much autonomy that we give the kids, we cater that schedule to them. So there's nothing specific, especially if we need to build in school. That may look different for all of the kiddos. We kind of change it up depending on the kiddos' needs.
Okay. Okay. Last, will Medicaid possibly pay for family lodging, having to go through their Medicaid case manager? Do you know?
Great question. I don't know. Okay,
We are not sure on that one. So sorry.
That's part of the story, but I could not comment. Okay.
I think we're out of time.
Yes.
We have more questions, lots of interest and excitement about the program. Okay, we have some online. We can get the questions to Children's Mental Health Program and they will answer them. Just a reminder, QR code on the door as you're exiting for the survey. Be back at 8 for tacos, 8:30 for the first presentation. People online, thank you for attending, and your survey link should be in the chat. And if you have any other questions, please let me know. Thank y'all.